Today we will discuss some concepts about EOG. The first description of EOG was given by Alvin Mark in 1951. Geoffrey Arden is regarded as father of EOG and he gave his contributions to EOG in 1962. What is the principle of EOG? Principle of EOG is that it measures the transepithelial potential, that is the standard potential between the cornea and the retina. And this standard potential between the cornea and the retina is the indirect measure of the transepithelial potential. What is the physiology behind EOG? The changes in the RPE, that is the base of the RPE cells have a calcium and chloride channels. So it measures the EOG measures the changes in the RPE. In the dark phase and the light phase, there is a change in potential. There is a change in potential which helps us to compare with the normal potential. In the light phase, there is intake. There is a calcium. There is an increase in the calcium intake from the electrodes, and the chloride channels open, which hyperpolarize the RPE cells, and we get a positive potential. So in the light phase, there is increased calcium intake, and chloride channels also open, which hyperpolarize the IP cells and give the positive potential. What is the setup needed for EOG? We need engineers to check the machine frequently. We need optical engineers for calibration of the machine. We have 5 electrodes, 2 electrodes for each eye, that is the medial and the lateral canthus, and one Gansfeld illuminator, and one electrode as the ground electrode. What are the prerequisites? Prerequisite for doing EOG is that the patient has to sit straight. The patient does not have to respond to the audio cues and only move to the visual cues. Pupil should be dilated. Lighting dark adaptation has to be okay, and full time has to be taken for light and dark adaptation, and there should be only one fixation light in the room, and patient should be able to move the eyes. How to perform? First, the skin should be prepared. The patient should not be sweaty because sweaty means the patient is overcharged. We should turn over of electrodes should be done because resistance increases if they are old electrodes. Dark adaptation patient has to wait minimum 15 minutes. Light adaptation has to be done in the Gansfeld and the light, and for light adaptation the illumination intensity there is 100 candela per meter square. Once a minute for 10 seconds, fixation changes have to be seen, and the average of these readings give the implicit time and the dark trough. In a diplopia patient, how to do EOG? We have to shut or patch one eye in the acquired diplopia. If the patient has total extraocular paralysis, we can't perform because can't place electrode behind the eye. The typical motion needed is around 15 degree. The people who do the electrophysiology test are the electrophysiologists, and the engineers have to come at least once a month, and once a day the calibration should be checked. What are the parameters to be included in the report? According to the International Society of ISCEV electro, there should be LP, light peak is to dark trough ratio, or the Arden ratio should be there in the report. DT amplitude, dark trough amplitude in millivolts should be there in the report, and the implicit time from the start of light phase to the light peak. These three things should be there in the report. Along with this, what all things should be there in the report is the pupil size, the adapting light source type, the inconsistent eye movements or difficulty in the test should be noted in the report. When is the report reliable? Test is reliable when waveforms are scarce, that is, the stimulus that is, the stimulus is okay, and the waveforms should be regularly placed. If the waveforms are not regularly placed, then fixation might not be proper or the electrodes are not proper. There are no rigged arrows. In rigged arrows, 12 millimeter for dark trough and 25 minutes for light peak. The background luminance should be okay. What is the link between photoreceptors and EOG? The same signal from the photoreceptors for EOG to come. So ERG response is needed for EOG because the signal has to come from photoreceptor to the RP for EOG to come. So ERG response is needed for EOG. ERG has to be positive for EOG to be normal. Diagnostic use of EOG. Diagnostic use is vitelliform dystrophy where it is clinically applicable. What is Arden's ratio? Arden's ratio is light peak divided by dark trough ratio. If it is more than 1.5, patient is normal. Less than 1.5, it can be significantly abnormal. More than 1.8 is normal. Less than 1.65 is significantly abnormal. What are the various clinical pearls for EOG? EOG is abnormal in BEST irrespective of the stage of the BEST. So BEST can be any stage, stage 1 to 5, but EOG has to be abnormal. And EOG helps in screening patients. EOG helps in screening parents of the patients with BEST. Why it helps in screening the parents? Because it can catch autosomal recessive BEST retinopathy. What are the fast oscillations in EOG? Fast oscillations in EOG come from the apex of the RPE, and it is because there is a potential subretinal space. And which channels are there for the fast oscillations in EOG? The potassium channels which are present at the apex of the RPE. These are the fast oscillator potentials. They change every minute. These give a sinusoidal shape. And in the dark, in this rather than a light peak, we get a dark peak because the apex of the RP potential and light trough. And because this dark peak we get from the apex of the RP potential. And what else we got get in this fast oscillation EEG is the light trough.